it's 101, so we're gonna, for the sake of time, we're gonna get going here, and know that I'm gonna divert myself every once in a while because the new Zoom format, I have to admit all participants, which I should have given some control to. We want to thank someone by the name of Judy Taylor. So she's our event organizer who does an amazing job. So thank you, Judy. So next time I'll put her on control so she can let people in. So thank you for joining us. My name is Chris Prue. Judging by the names on the list, seems I know a few of you, a bunch of you, in fact, and probably has something to do with the fact that you may own a DTS and we've communicated at some point in time. I've done this kind of talk a few times, and we've actually done it in person. So this is the first one we're doing it as a webinar. And I think one of the reasons that some people shied away from this, we've been trying to organize this for a while, was, does everything have to have CEUs attached to it? And, I've kind of always said the answer is no. I mean, sometimes we're just, as clinicians, we're looking for good information that can help us, with outcomes. And that's a dual-fold situation, and then help us with practice, help us with equipment, and so there's nothing wrong with that. When it comes to CEUs, a lot of state requirements dictate that it can't be about certain topics, it can't be a certain length of time, but we decided to offer this 30-minute. Hopefully it goes well, and certainly let us know. So I'm gonna put mine and Dr. Proctor's email at the end of this, and some of you are contacted specifically by one of your representatives. You can communicate with them as well. But I will provide this handout because I think it can either help you clinically, help a lot of us have assistants actually perform this therapy, so it could be helpful to them. And maybe even the patients, if you're trying to create some sort of information for the patients. So this is highly didactic. I mean, you just got to press a couple buttons on the screen there to initiate, the DTS pull patterns. But so let me share a screen. All right. Now you can decide. So you can make, this. You'll see my picture continuously, or you could shut it down if you want. That's okay too. I will attempt not to reference things in an itty bitty, video that you guys are going to see moving forward. But I will probably cut back to video so I can, show a couple of things. So the reason you're probably here is, you have a DTS system or you're interested in it. So this is product specific as far as DTS pull patterns go. I will say that, when we go through this, and you'll see that the DTS pull patterns were developed, well, they weren't developed, they are implemented and put into the systems as a result of, existing information. And to kind of start off with a little bit of a story, and again, some of you know this, I started working with a gentleman by the name of Chris Petros, who's been with Chattanooga for a long time, who's been a big part of chiropractic, a big part of me and my practice, and certainly education. So it's interesting when they approached me, and at the time I was a professor in Kentucky, and want to show me their new distraction system, and that's another term we'll talk about a little bit. But so I said, well, tractions, it's old, it really doesn't do a lot of the things I wanted to do that I use my hands for. And fast forward to probably about a year later, after we finally got through all that and the new development of the traction system and the traction head, it was really built for kind of two groups of people. One is to address this market in decompression, and then the other was to address a little bit beyond that, and that's kind of where the DTS came from. And so when we did move forward, or people moved forward. I wasn't part of the company at that particular moment in time, but so they they focus really on the decompression components, and especially if you've ever had the in-service, just because there's an infinite combination of things that you can do with these devices. So the implementation of the DTS pull patterns, and really what we're trying to, sort of discuss today, is about improving utilization, and then hopefully that's also going to have something to do with your improvement in your outcomes. And I said that's twofold. So the nice thing about outcomes is they're good for your practice, right? So when people are happy, you're successful, and there's high patient satisfaction, then there's a greater tendency for those patients to refer newer patients into you to come back again, family members and that sort of thing. And if you are a chiropractor, and even some of the newer physical therapy models, if you are a physical therapist, that we enjoy this member type of system, to where some people have been in a practice as a member, as a patient, for 20, 30, 40, 50 years, however long that chiropractor has been in business. So we want to thank Script Pesco for teaming up with us and kind of sticking with us to see if this was going to stick, and judging by the number of registrants. And even though the total number might seem a little bit lower, we had a lot of people register. It just in short notice, people had to work, and we're going to be seeing patients. And so this is going to be recorded, and we'll let y'all know when it is posted, and you can go back. And again, if you have other clinicians and Dr. Brian, I don't know if you're watching. I missed the rest of the people that joined in, but I know some of your colleagues are going to be working, so it will be recorded. So to look at the DTS pull patterns, and first off, let me say that nothing's magic. Although I kind of view, and I look at decompression as somewhat magical. It was kind of game changer in practice. And I think for a lot of people, and someone like me too, because even at the time, I wasn't a disc sucker back or inner, and so what was more appealing to me was actually the utilization of the DTS pull patterns, or the combination of all of the different things that we could potentially do. And so that was crucial to me, because my goal at that time, especially, a lot of sports medicine. Yes, we did see some disc herniations as a result of injury, but that acute phase, we don't really pull really hard, and we have some different opportunities that we'll look at. So, and those of you that don't know me, yes, I am a chiropractor, and Dr. Proctor, also a doctorate and athletic trainer. My other colleagues. So we'll show you some emails here at the end. But so our goal in this is to sort of cover what they are, and hopefully give you some indication as to use them. So like I said earlier, they're built on manual therapy utilization. So the predecessors to these guys, and I used to always talk to people like everyone's heard of Maitland, and everyone's heard of Kaltenborn, and depending on where and when you went to school, that's not actually true. So it's not consistent across the board, and in the direction that they were in, maybe depending on the courses that you took, and again, wherever your program was and whatever you did, you may not be familiar with them, but they are manual therapists that kind of sort of develop this criteria for some of these things. And so that's why when we look at the DTS pull patterns and where did they come from? And actually I had a colleague ask, well, where's the literature on all this? Well, read anything by Maitland, Cyriax, Kaltenborn, and Manel, and you're going to see a lot of that stuff. That's where it comes from. And so we give credence, to them. And well, why bother? Well, if you've ever heard me speak before, I joke it. I'm getting tired, No, I'm not really getting tired, but my patients at the end of the day deserve the same kind of care as the patients that come in at the beginning. And so that's important to me to maintain efficiency. And And, you know, I was joking with a patient yesterday, and, you know, why are you here today? You know, she's just doing a follow-up, but she's like, you know, I work with kindergartners and I'm on the floor all the time. She's like, any recommendations? And I'm like, yeah, get a stool, you know, and train, right? And I said, you know, it's the same thing for us. I mean, obviously we're in very physical professions, and, you know, kind of like training for an athlete. So it's good that you take care of yourself. And so one of these things, you know, also for the longevity, but consistency in patient care, you know, so if you've learned, you know, extremity manipulation, extremity adjustments, then you probably see the value in those. And it's not dissimilar to what we do in the spine. So most of us know, you know, the chiropractic manipulation and the adjustment. And so that's one of these extensions, right? So when we look at, you know, the patient management approach and why we have these different levels and the different criterias of manipulation, they sort of help us to dictate, you know, what can we do with them? And that's why I say there's no magic. At the end of the day, it's still all about, you know, why is there an indication for certain things? Hopefully we'll dispel some of that and provide some information over that. But like I said, so these are based on the mobilization criteria, and we'll cover these in a second. Really two more consistent ones. So I like to cover Maitland especially because I think that does you know, Maitland's criteria does a great job at, you know, outlining the levels at which we have sort of available to us. And, you know, the biggest one, which to me is also the highest order, and everything is subsequent to that. So everything I do for the most part is to get me to that point to where I can perform, you know, the adjustment, right? So, you know, when I was first approached, like I said, if there was a way that I can get to that more rapidly and also do some really good things with those acute patients all the way to the other end of the spectrum, the chronic patients, and then even what we do today, which is beyond that, which is actually for performance conditioning. And that could be another story that maybe you want to hear, maybe you don't. But anyway, so how can I get to that sooner? And that's not a new concept, but it kind of is a little bit more challenging in the spine. If you want to pull long axis traction on someone's cervical spine, you know, and do that for 10 minutes, you know, bless you, because it's hard, you know, and if you want to do that on all of your patients, it's really hard, you know, to be able to accomplish that. So that's why, again, I say, you know, sometimes it's as we're addressing the patient and kind of feeling them out, right, and seeing what it is that we need to facilitate all of those changes. And like I said, again, at the end is sort of getting to that highest order, which is manipulation. I mean, here's the best part too, is, you know, when we do this right and when we sequence appropriately, even if you're just doing regular distraction, so it influences different sensory beds, you know, when you're doing a mobilization versus manipulation, and most people are familiar with that concept. But, you know, as a result of that, it also has an influence on potentially the outcome. So we did well, I think my studies are cool, but we did a project, and we looked at the sequence of events, and we looked at, you know, combining manipulation with mobilization, actually even simultaneously. And I'll get to that in a moment. And again, that could be another discussion. But so, you know, the points here are, how can we better utilize this and maybe, you know, a little bit of advancement and think from the manual clinician's perspective, kind of like what you do in the rest of the body. So when we look at, you know, where are these based on? Well, they're based on biomechanical and neuromechanical data, right? So looking at the neurological effects as well as the tissue constraint effects, you know, the biomechanical, you know, stress strain relationships and what it is that that we're trying to accomplish. And so I think it's also important, and I tell people this a lot, you know, it's not about feeling it, right? So typically when we're looking for patient feedback, I want to know if I've gone too far, right? There are occasions to where it's like, okay, can you feel something? because what we're really trying to establish is the lower limits and the upper level limits. You know, when it comes to biomechanical data, what's beautiful about that is it's just that, it's biomechanical, right? So it's physics, and yeah, we can argue with physics, we can argue with mathematics to some extent, but it's very predictable, and that's what's, to me, fantastic. So when you know your device, such as, you know, this table begins to separate on a patient, right, L5 from the sacrum at about 25 to 30 pounds, which is why my starting point is always 30 pounds, because I know that's the initial point where we start to see consistent separation significantly of the vertebrae. People think, well, wow, you know, that's big. No, remember, statistics is, you know, it's a challenge to read through and understand, because the statistics of it, you know, it's minuscule. I mean, we're only talking a couple of millimeters, but clinically, that's actually significant, right? So that's why that's important, and why we look at, you know, a lot of the biomechanical data. So if we look at that, and then, you know, we've applied this, and again, many of us have that experience in the extremities from that clinical aspect of why we do different grades, and that's again where the DTS pull pattern. So let's look at Maitland's grading criteria. So there's 5 different levels of mobilization. Skip to the end, and grade 5 by Maitland. Wasn't a chiropractor, so we didn't call it a chiropractic adjustment, but it's a high velocity, low amplitude manipulation, right? So it's a form of mobilization, but it's listed as a manipulation, or the chiropractic adjustment. So then we've got, you know, 4 other levels prior to that. What do we mean by that? Well, it usually means either range of motion, the amount of force, or a combination of those things, right? So when we look at grades 1 and grades 2, they are really that lowest order, right? And those of you that perform something like post-isometric relaxation, PIR, which is a form of PNF, proprioceptive neuromuscular facilitation. We like our acronyms, don't we, right? So remember that that's, first off, it's not at end range, it's not a high degree of force, and we are using patient assist with that, right? So there's actually some contraction. So why is it considered a grade 1? Maybe a grade 2? Well, it's because of where it occurs, the amount of force. And so that kind of indicates that, well, we can probably use that during an acute phase stage of injury. So we look at the grade 1 and the grade 2, and we can also add some rhythmic amplitude or oscillations to it. And again, when you look at your system, and hopefully you know this, but you can change that time frame. You can actually go all the way down to 0 seconds, and we'll look at one of the DTS patterns that, you know, was built off of that. So we can actually create oscillatory pull patterns, right? Even from a custom perspective. So the grade 1, very small amplitude. Grade 2 is a larger amplitude. So if it's a small amplitude and it's at the beginning range of motion, you're not at end range. So you're not overtly stressing the tissue. Well, what does that mean? Well, that means that you're getting through the initial take up or slack, which is predominantly going to be the muscle tissue, right? So we have to go through muscle tissue, take up the slack before we can get to the connective tissue and some of the other structures like the joint capsules, right? And then so the grade 2 is going to be a larger amplitude. There's also going to be more force, but it doesn't take a lot of force and a large amplitude through the end range. So grades 1 and grades 2 are often utilized during some of those earlier phases, but they're also very, very comfortable, and I'll comment on this again, but what it also does is it results in mechanoreceptor stimulation. So I don't know where, if I learned this from someone or, you know, inadvertently, because I ask a lot of other chiropractors and other, you know, manual clinicians that, you know, you do a manipulation and adjustment and then you pull. And maybe you just hold it, or maybe, you know, you oscillate back and forth, not with a high degree of force, not with a great amplitude. And I've seen people do this, you know, when I visited clinics and whatnot, and I asked them, why do you do that? Oh, you know, it makes the patient feel comfortable. Well, there's actually a reasoning behind that, and it's legitimate, and it's a grade 1 or a grade 2 mobilization technique, and it's used often in conjunction with grades 4 and grade 5, because that mechanoreceptor stimulation can result in muscle activity, myoelectrical suppression, but also pain reduction. So when we're doing these higher orders, or what also may include some higher intensities, these smaller rhythmic and lower force oscillations actually have quite a benefit to them. And you'll see that. So as hopefully, if you've looked at these pull patterns, you'll kind of start to think about, you know, why some of them are built that way, and you'll see how this is embedded in there, all the way up to, you know, the grade 4, where we have very small, but we're closer to end range, right? So we're pushing those limits, and then of course, you know, with a grade 5, we're in that paraphysiological space, which is, you know, the chiropractic adjustment, right? So that's Maitland, and then I bring in Kaltenborn. So Kaltenborn is specific to traction, although they do use a initiated utilization of a perpendicular force, but I use it also to simply describe, you know, some influences when it comes to traction. The other reason I talk about Kaltenborn is because this particular system, so I have mechanical table, and then I also have line pulley tables. I will say that I gravitate towards line pulley systems specifically for this reason. It's easier to create a coupled motion effect, right? And so we kind of do that to some extent when we are performing a manipulation, an adjustment, right, with our setup. That's why we go into certain joint positions, so we can preload and things like that, and address the arthrokinematics, right, the way that a joint or an articulation actually moves. Well, sometimes we don't want to perform that setup because that maintenance of that position, right? I mean, putting me in side posture and putting me at that position right before thrust, imagine holding that for 30 seconds or 60 seconds. And I actually do that with some patients on purpose, but not before I do a manipulation, because you may not get the effect that you're looking for. So imagine holding that at end range, and that may not be very comfortable, you know, for a lot of people. So sometimes we don't want to create, you know, all of that setup, and in fact, we want that coupled motion effect. So I'll use the example of, you know, the MCP, the second MCP, your index finger, right? So imagine I put myself into extension fully, and then I pull distraction on that, versus pulling distraction first and then going into extension, right? So the resultant, the end point is the same, but how we got there was actually different. And the effects are going to be different too. So we're looking at the primary vector. And that's why when we look at traction, the primary vector is, right, it's going to be axial, it's longitudinal, and then everything else is going to be secondary, which to me is actually a good thing. So when we look at, you know, the grading of Kaltenborn, they're very, very similar. And so with that, we can start to think about, you know, maybe there are some other things that that might be going on, and I'll, you know, talk about these in a second. So that's kind of what I'm getting at when we talk about these resultant force vectors is, you know, what are we trying to accomplish, and what can we get from that, right? So the initial vector, and always, always, always the primary vector, at least in this device, is going to be axial, right? So it's going to be longitudinal, it's running parallel to the spine, okay? Anything else is going to be secondary, which to me, again, is a good thing, right? So distraction is an all-encompassing term that sort of describes anything that separates the two adjacent components, right? So flexion distraction is in there, decompression is in there, traction is in there, right? But when we look at decompression, you know, specifically that primary vector is going to be axial. And then because of what we have available to us, when we look at the system and the way it's designed, right? Here's a teaser. Here's the new belting system, right? So this actually clips here. But what I want you to look at and notice on your belting systems is you've got 2 contact points that's closest to the table, and then you're going to have one further away from the table, right? And you know your belting system's always the same regardless of whether they're prone, supine, or sideline, right? So when we have that, and you pull equally, right? If you're exactly in the middle, then the moment arm lengths on each side is going to be equal and you're going to get a straight line pull. But when you change that angle by lowering or elevating the height of your table, you're actually going to change that resultant vector. And the reason is because that O-ring moves, and when that O-ring moves, it creates a change in the moment arm length. So what do we get with that? Remember, it's primary, but the resultant vector is now going to be at an angle. So we're going to get this perpendicular lift pattern to it. So again, think Kaltenborn. And what do we get? Well, when we're in that supine position, we get a posterior pelvic tilt along with axial distraction as the primary vector. And then when we're in the prone position, we get an anterior pelvic tilt, right? I won't get into, really what we're going to do with all of that, but know that, that's kind of available to you, and think about where that might be beneficial, right? If you wanted to separate anterior vertebral bodies, add an extension lordotic moment into your distraction, think about that. Or a posterior pelvic tilt, increasing opening of the posterior elements in the lateral canal, think about that, if there was something that you wanted to do in there. So when we look at, well, why do we want to maybe combine some of these things? Part of it is the sequence effect, and then the other part, again, is mobilization is different than manipulation. So mobilization 1, 2, 3, and 4. And on your systems, you can actually mimic grades 1, 2, and 3 for the most part, potentially, a grade 4, right? So if you think about, again, that opportunity. Okay. So DTS Pull Pattern 1. This is just your classic. So this was modeled after the VAX-D. So patients that typically have your disc herniation, classically, that's where that's going to fall, right? That's the indication. And when it defaults to this, it's pretty simple, right? So there's not a lot of things to put in there. All you really need to do is put in your max and min level. Let me put a note about that too. So, and maybe, again, you guys let us know, what do you want to hear more about? But, the minimum level should be 70% of the upper level, right? And there are reasons for that. Same thing, you should have at least a 20-second progression and regression phases when you're doing this. And it's neurological. Those are the reasons behind it. But so there's not a lot of parameters to put in. And what I love about a system that has a very low coefficient friction design to it is the spine is the spine is the spine, right? So we start and everyone gets pulled at either 30 or 40 pounds, which is nice because we don't have to do math. There's not 1,000 different protocols. And so 50% of body weight plus 10 pounds is antiquated. It has nothing to do with a split table design. And so that's why it's important to understand that and what you can do. So DTS Pull Pattern 1, that's your classic. Love, love, love me some DTS 2 pull patterns. Why? Because it is kind of your classic. So what happens, when we start to pull, right? We get relaxation of muscle tissue. If you've done your progression phases appropriately, you should be able to get there, right? But think about these chronic patients. They've had these conditions for a really, really long period of time. Well, what happens when you get that? Well, you get further separation, right? Your system has what's called the servo motor, that they supposedly put in only $100,000 units. That's like $300 in your automobile that has, an electronic suspension system. So it's not that expensive, but it's a mechanism that helps to respond to the feedback, right? So as your patient starts to relax, and then it's always going to pull until it meets that level of resistance. So the DTS2 pull pattern allows for additional mobilization at that end range, right? So when I talked a little bit about saying, well, what levels of mobilization can we create? 1, 2, 3, and kind of 4. Here we go. Why is this good? Because it's mimicking stuff that I do not want to have to do with my hands, that I value highly because I do a lot of mobilizations in the extremities. So this is a really good protocol for people that are the chronic and people that you're looking for that later phase. So typically we will go through a level of your standard decompression, like your DTS Pull Pattern 1, and then this is potentially that next phase, okay? And this is probably even a further progression to that. So reduction in the intensity. And the reason is, remember creep, stress-strain relationship, right? And so when you start applying stress to a tissue, it results in strain, a deformation to that tissue. It maximizes in biological tissue in about 6 minutes if you have the appropriate balance. And so we have an opportunity. Do we let them go, or can we have this stepwise effect? And the reason I like this stepwise effect and why we go back to the 70% when I'm doing your standard is because it's like a rest phase. And if you've ever like trained for a running event, you know, when we're trying to push, you know, the lactic acid model to the right, you know, that's why we run sprints, right? So we go into an anaerobic state and then we bring it back to train someone to run at a higher level percentage of their VO2 max. Maybe that's not the best, most confusing analogy, but the point is that we're trying to enhance, you know, that level of mobility. So this is another one that works really, really well for these chronic level patients that we're trying to get more influence at end range. So this is one that I like to do if they're in the clinic long enough, and then we start to implement, you know, extension moment exercises like McKenzie and things like that. It really gives some great mobilization. DTS4, I think, is another great one. I love this one especially for my older patients, patients that have multiple levels of degeneration, and patients that might be a little bit resistant to care, right? And so what it does is it's your grade, and depending on the amount of force that you use, it's a progressive grade 1, grade 2, going up to a grade 3, you know, Maitland mobilization. That's awesome because I don't have to stand there and do that. So it's a great initial phase to creating mobilization, right? And so again, you have the opportunity to set, you know, a lot of these parameters, including your start and the amount of progression, right? I like the 5 pounds. I think when we go higher than that, it's a little bit more of a challenge. And again, especially in the cervical spine, so that's in lumbar. In the cervical spine, it's more like 1 to 2 pounds, right? Because 5 pounds would actually be a lot if you're starting at 0 and looking at, you know, the overall number of steps, and you get to control that hold pattern. Wonderful, wonderful, wonderful. Older adults, chronic, multiple levels of degeneration, right? You ain't sucking the discs back in because they don't have anything left, but we do want to create elongation, mobilization. So when we give them those exercises, tissue extensibility is there, mobility is there. It actually makes it more comfortable and arguably even a better outcome when it comes to some of those other ones. Here's your great mobilization, right? And another potential talk would be getting into, well, I use cervical decompression distraction when I treat shoulder conditions. I use lumbar when I'm treating hip conditions because of what it does neurologically and just overall biomechanically and what we can accomplish from that. And, you know, think about all the relativity and the adjacent structures. So the DTS5 pull pattern is a mobilization. It's a 0 hold pattern. So what happens is when you get to the upper intensity, as soon as it reaches, it goes right back down. As soon as it reaches, it goes right back up, right? And again, so what happens is you can set this at very low intensities, right? For the lumbar spine, if I have an acute patient and I want to do this oscillation, or subacute patient, I can use this pattern at a 30% speed. And that 30% speed, it's very comfortable. And keep in mind, they don't feel that because they've got very poor, you know, 2-point discriminations, theresthesia, graphesthesia in the lumbar spine to begin with. And if you crank this thing up to where they can feel it, you're probably going to overdo it in some of these patients, especially the acute ones. So this gives me a great mobilization technique. So I remember the first time, you know, I had a gal come in. She was a college university softball player, rotator cuff repair, and just being in the sling, you know, starts to get, you know, the cervical spine problem. So they come to me, athletic trainer, and they're like, hey, you know, what do you think we can do here? So I put her on this mobilization pattern because it was awesome. That's all we needed to do. And you know what? I wasn't going to stand there and yank on her head, you know, for 10 or 15 minutes. So I would always do manipulation following these particular procedures. So the DTS5 can be used during the acute stage, which is really, really good because it's essentially a grade 1. You can make it a grade 2. You can potentially even make it like a grade 4, right? We've got 0, 0 hold, and we have 30, 50, and 100% speed. So when I want to move it more rapidly, we're never going to replicate a grade 5 with this device. So it's not taking place of that. I use it for what it's designed to do, which is mobilization, right? And because of the line pulleyed system, so I do a lot of blocking too when I have patients on distraction, because I want to create that coupled motion effect. But let's say, you know, orthopedic block, I couldn't even, it's been so long since I learned anything about SOT. Nothing against it, I just don't do it, but I do use the blocks for that. But from, you know, an orthopedic or Gillet standpoint, fantastic, you know, doing that. So I'm setting up patients for that coupled motion along with the belting system, you know, by creating, you know, the angulation. The angulation is purely for that. The angulation, we can maybe, well, I've got a video set up. Shoot me an email if you're interested in setting angulation and why or why not. And I can send you that video. Teaser, man. I don't know if some of you are at Parker, but I love me this table. It's the 6E. So it does everything, you know, my TRT 600 does still, but it's all electronic, right? So even the pelvic tilt, it also has warming to it. There's lights, another discussion for that. Reason why, just think patient satisfaction. I'm in New Hampshire, so keeping people warm in the wintertime is great, but great, just awesome table. Take a look at that. Talk to your folks at Script Pesco. I went over by a few minutes. I apologize. Anyway, chris.prue, djoglobal.com, rick.proctor, djoglobal.com. So we have Chattanooga Clinical Education. We have a web page. Like I said, we can send this to you, and I'll talk to Judy about sending it out, or, you know, contact one of us, either, you know, through the event organizer, through your local representative, or communicate with myself. So Dr. Proctor and I, that's what we do, and it's job security. So I got to let them know how many people I talk to every day, and I'm running out of names to make up. Just kidding. But anyway, if you have any questions, you know, give us a holler. And so we're always trying to make some new things. I hope this was beneficial. I know we went rapid, you know, near the end, but it's not rocket science, and that's why it's related, you know, kind of back to what a DTS pull pattern is. And you know what? I did what I said I was not going to do. And that was referring to stuff on my little video screen, right? So this is the new belt. I guess that's a teaser too, the new belting system. But again, look at, you've got 2 here and 1 connection to the front, and why it makes that angulation to it. But overall patient setup. If you're interested, you know, maybe we should do another one on some of these nuances in patient setup. And I also have a series of exercises that I think people should do to capitalize on what just happened. And, you know, we can get into some of those more neurological effects. So looks like everyone kind of hung in there. I appreciate your time. Hope everyone's safe out there. I know some of us are busier than ever. Diversification in patients coming in has grown dramatically. Again, another reason to really kind of improve the efficiency in the clinic. So we're going to cut out because we did go over the time here, and I want to be cognizant of your time. But like I said, we will record this. It will be posted. Let us know if you're interested in some other things. We're going to do it anyway, but let us know, you know, maybe my topics of interest aren't the same as yours. So let us know, and we will, we'll see what we can come up with. All right. Have a great day.